Hello student, Assalamu alaikum. Good morning. Today we are topic is postoperative complication and its management. It is important in your professional examination in Viva board, and sometimes it is important to your written examination. In postoperative management and its complication is system division. There is several system in our body and we are divided in them into broad headlines. First of all, we are talking about the cardiovascular system. The cardiovascular complication in postoperative ward is such as cardiac arrhythmias, myocardial infarction and new onset myocardial infarction, hypertension, hypotension, bradycardia, tachycardia. So, you must know the blood pressure of the patient intraoperatively, preoperatively. If the patient is preoperatively hypertensive and intraoperatively hypertensive, the patient might be acute attack on postoperative MI or postoperative arrhythmia. So, you must proper follow up the patient in postoperative ward such as cardiovascular system follow up, respiratory system follow up, body temperature follow up and metabolic system follow up, kidney system follow up. So, there is many types of follow ups. Very important follow up you should know in postoperative ward, that is respiratory rate, heart rate, blood pressure, urine output, partial pressure of oxygen is called oxygen saturation, temperature and dressing. And if you can do the proper follow up, you can understand the complication. Now we talk the complications properly and its management. First of all, we talk about the cardiovascular system complication. Cardiovascular system complication, there is first complication is if the patient is spinal anesthesia, then the first complication will be the hypotension. So, when you go to the postoperative ward and then see the patient is hypotensive, then what should you do? You must see the urine output and the dehydration level of the patient. If the patient is dehydrated and urine output is low and patient is tachycardic, then must be the hypovolemic shock. So, what is this management? Management is first of all running the fluid and is called isotonic fluid. Then check the urine output and check the dehydration level and check the pulse pressure and check the pulse. And if fluid is adequate but patient is hypotensive, then we use some drugs, that is the vasoconstricting drug. First of all, we can use the ephedrine. Ephedrine is mixed drug, is act on mixed sympathomimetic drug, it act on alpha and beta receptor, and it also increase the heart rate and increase the blood pressure. And you can use ephedrine 1 to 2 cc and increase the heart rate. Then what is the complication? Then another complication is hypertension. If the patient is pre-existing hypertension and the patient is inadequate drug and intraoperatively when withdrawal of the general anesthetic drug, then again any sympathetic stimulation, that will be the pain and hypoxia or any other sympathetic stimulation, there will be the again hypertension. And the complication of postoperative hypertension is mainly is postoperative MI or stroke. So, when you see in the postoperative ward the patient is hypertensive, then check also the pulse. If there is arrhythmia, then the patient is going to be shock. Or when the patient is stroke and the patient is maybe MI, so you should start the hypotensive drug, and mainly you can use in postoperative hypotensive drug is nitrates, is called GTN, and it easily available, and you can use nitrate 0.01 microgram to 0.02 microgram per kg per minute, and its short duration of action and is stable the systemic and diastolic blood pressure. Another complication is arrhythmias, and you can also maintain the arrhythmias by maintain the blood pressures, and see the patient is hypotensive or hypertensive or hypoxic. Any sympathetic stimulation can causes arrhythmia, so must blunt the sympathetic stimulation. That's all about the postoperative complication in cardiovascular system. Another postoperative complication is respiratory system. We should check the respiratory rate, respiratory pattern, and the partial pressure of oxygen is called oxygen saturation. In postoperatively, there is a common respiratory complication is hypoxemia, respiratory obstruction. And respiratory obstruction or airway obstruction, there is two type of airway obstruction. One is partial airway obstruction, another is complete airway obstruction. In the you must know the differentiate what is partial airway obstruction, what is complete airway obstruction. If the patient is inspiratory stridor and respiratory rate is high and noisy inspiration or respiration, there is must inspiratory stridor and there is partial airway obstruction, and oxygen saturation is slowly drop and patient is restless. Then what is your management? Must see the airway. The cause of partial respiratory airway obstruction is secretion, mainly secretion, and after the tonsillectomy or any thyroid or any operation in the neck or mouth, there is some collect the secretion, and this secretion can cause partial airway obstruction. So what should you do? You should clean the airway by suctioning and pattern the airway by give the airway in the mouth and give the oraraxon and left lateral position to clean the secretion. And if the patient is complete airway obstruction, there is no noise, there is no inspiratory stridor, only patient is going to be rapidly sinussed and paradoxical movement of the chest wall. So the main cause of complete airway obstruction is tongue fallback. If the patient is deep, conscious and the consciousness level is not adequate, then the genioglossus, which is the main muscle of the tongue, which is the protective muscle, is do not proper of his action, and tongue is go to the fallback, and mainly tongue can causes the complete airway obstruction. So you should keep the airway in the mouth. And another cause of complete airway obstruction is going in recurrent laryngeal nerve injury in thyroid surgery, or in the thyroid surgery there is blood clot which can compress the trachea and causes the complete airway obstruction. It's called airway obstruction, is a complication, and another complication is hypoxemia. Hypercarbia is the main another cause of respiratory complication in postoperative ward, and it is mainly causes in bronchial asthma, COPD patients, because in the bronchial asthma and COPD patient the airway is already compromised. After extubation there is mainly maybe the laryngeal edema and causes the airway hyperactivity, and there will be the bronchospasm, and this bronchospasm can cause the airway constriction, and this airway constriction main causes the hypoxemia and hypercarbia. And the sign symptom of hypoxia, mainly the patient is restless. Then slowly the patient is cyanosed, and the patient partial pressure of oxygen or partial oxygen saturation is dropping. So you should, if the patient, you are already know the patient is respiratory or infection, or the patient is airway hyperactivity such as bronchial asthma, COPD, then you should use the bronchodilators, mainly short acting bronchodilators, salbutamol or nebulization, and use the steroid and clean the secretion. And hypercarbia causes the increase the intracranial pressure, and patient is slowly unconscious, and carbon dioxide itself make the respiratory acidosis, and respiratory acidosis causes the patient is deep sleep, and slowly the patient cannot breathe. Is all about the respiratory complication in postoperative ward. Then we should start the metabolic complication. The metabolic complication is mainly two types. They are mainly hyperglycemia, hypoglycemia, diabetic ketoacidosis, and hyperosmolar ketoacidosis, It is mainly the metabolic complication causes in the patient of pre-existing diabetes mellitus, and in the OT or any stress factor, and operation is another the stress factor can causes the increase the blood sugar level. If the patient is not properly well controlled diabetes mellitus, the postoperative diabetic ketoacidosis is very common, and postoperative diabetic ketoacidosis we should follow if the patient is diabetic mellitus, must see the blood sugar level, and we can allow the blood sugar level in diabetic patient is 8.1 or 8.9, and if the blood sugar level more than 10, we should start the sliding scale insulin or the neutralizing of the insulin dose, and we must start, if the blood sugar level is more than 10, must start the short acting insulin. In postoperative ward mustly use insulin, and which is short acting insulin. And the patient, if the patient is hypoglycemic, and sometimes the patient may cause the hypoglycemic, and hyperglycemic and hypoglycemic is the hypoglycemic is the mainly the most complication, the most life threatening complication, which must be managed by 5% DA or 25% DA running, and 25% DA running, and within the 5 minutes of diagnosis the hypoglycemia, and hypoglycemia must be very important than the hyperglycemia. Hyperglycemia is give the time to patient deteriorated, but hypoglycemia do not give the time to patient is already deteriorated as very soon. And you can see another follow up, there is urine output, is called kidney system. Urine output follow up is important, because if the urine output is not adequate, the postoperative AKI is very common, and it is life threatening, and is very much complication, it is very much deleterious and noxious to the patients. So, the urine output is very much important, and when the urine output is low, when the patient is hypotensive and when the patient is shocked, and such as in the hemorrhagic patient, shock patient such as rupture ectopic pregnancy, rupture uterus, or intestinal obstruction or perforation, there is so fluid loss or electrolyte loss or blood loss in intraoperative or preoperative, then postoperative urine output is very much important. If the proper urine output is not occur within 24 hour or 8 hour or 6 hour, the patient is going to be the AKI, and the postoperative AKI must first of all we use the flutamide, and it is a diuresis, diuretic drug, and help to increase the urine output and increase the fluid volume, mainly the isotonic fluid, normal saline. Patient is see the hydration level, is the patient is dehydrated, correction the hydration, then drug and in the drug we can use mannitol or we can use the flutamide, and mainly see laboratory finding, we must see the creatinine level. The creatinine level is high, then postoperative AKI management will be the dialysis, and it is hemodialysis. And another postoperative complication is postdural puncture headache. Postdural puncture headache is most common in gynae and obstetrics the patient when there is a spinal anesthesia, and the main cause of PDPH or postdural puncture headache is CSF leakage, and it is occurs after the 24 hours. The characters of postdural puncture headache is the nocturnal headache and occipital headache is radiating in the frontal lobe, and the postural headache such as when the patient is posture change such as lying to sitting down, the headache is increased. And sometimes there is the tinnitus, sometimes there is photophobia, and sometimes there is vomiting, and it is mainly occurs in young female patient. So what is his management? His management is যেহেতু এখানে CSF এর লিকেজ হচ্ছে, তো আমাদের কি করতে হবে, আমাদের CSF এর প্রোডাকশন বাড়াতে হবে। তো CSF এর প্রোডাকশন বাড়াতে গিয়ে আমাদের কি করতে হবে, আমাদের হচ্ছে ফ্লুইড বাড়ায় দিতে হবে। ফ্লুইডের মধ্যে হচ্ছে মেইনলি 5% DA ইউজ করতে পারি, অথবা আইসোটোনিক ফ্লুইড ইউজ করতে পারি, অথবা পেশেন্টকে বলতে পারি আপনি বেশি করে পানি খান। আর এছাড়া আমাদের কিছু ড্রাগ আছে, ড্রাগের মধ্যে অ্যান্টি মাইগ্রেন ড্রাগ আছে যেগুলো হলো সুমাটিপ্রিন, or we can use the vasoconstrictive agents such as caffeine, and we can use the low analgesics such as paracetamol. Paracetamol can easily subside and is easily available, and reassurance the patient যে আপনাকে বলতে হবে যেটা আপনার এমনি হতে পারে, সবারই হয়, তো এটা আপনাকে একটু ধৈর্য ধরলে 4 থেকে 5 দিন পরে এটা এমনিতেই চলে যাবে। আর এটা তারপরে যদি এটা না যায়, দ্য ডেফিনিটিভ ট্রিটমেন্ট হচ্ছে epidural blood patch. Another complication of general anesthesia is sore throat, because we can use the endotracheal tube and causes the laryngeal edema, and after the laryngeal edema there is causes the sore throat, laryngitis, and it is managed by steroid, and it is easily managed by steroid. And another postoperative complication in hypothermia, it is mainly occurs in children. The children is easily hypothermic, so warm the patient. And another postoperative complication in young female and children is postoperative nausea and vomiting. And postoperative nausea and vomiting managed by preoperatively the patient is 6-hour NPO and proper hydration maintained, and give the patient antiemetic preoperatively or give the patient steroid or anti-ulcerant drug, and we mainly many general anesthetic, mainly the nitrous oxide can cause postoperative nausea and vomiting. So in the summary, what should you do in the postoperative ward? You must do the follow-up properly. First of all, see the patient, the consciousness level of the patient, then the respiratory rate, pulse rate, blood pressure, partial pressure of oxygen, urine output, temperature, skin condition, and see the patient whether the patient is dehydrated or not. If you should do the proper follow-up, you can easily manage and easily understand what is the complication, and you do the complication easily and manage the complication. There is nothing to worry about, and if the patient is deteriorated, then we should transfer the patient in high dependency ward or ICU. It's all about today's topics in postoperative complication and its management. Thank you.